Good day. I am now here to share and discuss about the important role of vitamin D in our overall health. Thank you to Hyphens Pharma for this D Cure 25,000 IU oral solution for my presentation. I am Dr. Gisela Trajano Sarmiento. So the vitamin D plays an important role for overall health. It is known to be essential in bone health, but increasingly research is revealing that the importance of this particular vitamin is also very broad in almost all health problems. It acts as a powerful immune modulator. It fights off invading bacteria and viruses, prevents acute respiratory tract infection. That's the reason why this lecture is very, very timely. It reduces the occurrence and severity of lung illnesses such as community acquired pneumonia. So the role is now clear that it has roles in addition to its classic effects on calcium and bone homeostasis. So the classical actions of the vitamin D are to promote the calcium balance and to promote bone health. Vitamin D absorption of calcium in the small intestine and stimulates the osteoclast differentiation and calcium reabsorption of the bone. I will show this further on the synthesis lecture. So vitamin D additionally promotes mineralizations of the collagen matrix in the bone. So as a receptor, it expressed also on the immune cells for the immune systems, both on the B cells, T cells, and the APC. Now, these immunologic cells are all capable of synthesizing the active form of the vitamin D metabolite, and the capability of the vitamin D in acting in an autocrine manner in a local immunologic environment. So, the vitamin D can modulate the innate and adaptive immune responses. It's associated with increased autoimmunity as well as an increased susceptibility to infection. So as an autoimmune illnesses are responsive to, these also are ameliorative effects of the vitamin D, wherein it has a beneficial effects on supplementing this vitamin D deficient in individuals with autoimmune illnesses and may extend beyond effects on bone and calcium homeostasis. So the immune system defends the body from foreign invading organisms and promoting the protective immunity while maintaining tolerance to self. So the implications is that if the vitamin D is deficient on the immune system, it has become clearer now that in recent years and in the context of the deficiency, there appears to be an increased susceptibility to infections and diaphysis. And this is actually genetically susceptible host to autoimmunity. Now this table I really love is because it shows a lot of the natural sources of the vitamin D and its content and how the it's able to give also the IU units that we need on a daily, the RDA recommended daily dose. You have the cod liver oil, salmon fresh, and from which it's about actually 1000 IU already. Now if you go down the list, it also has the sardines that is even canned, the tuna, the mackerel, which are also within the RDA. The shiitake mushroom, which about 1,600 IU, especially if it's sun-dried. The egg yolk that we always consume every morning also contains 20 IU. Now, the sunlight UVB radiation is really, really paramount. It has the 20,000 IU that we need, which is already equivalent to exposure to one minimal erythemal dose MED or in a Bayring suit. So meaning if we go on our beach and exposure of arms and legs to 2.5 med is equivalent to ingesting already 3,000 IU of the vitamin D. There's also some fortified foods as you go on the list. But the vitamin D, which is ergocalciferol, that is pharmaceutically sources in the United States, is actually 50,000 IU on this particular capsule. So with this, let me walk you through just a bit on the vitamin D metabolism and synthesis. Know that it's a fat-soluble vitamin. It resembles sterols and in structure and functions like a hormone. During a cholesterol synthesis, the 7 rather dehydrocholesterol is formed as an intermediate, so upon sun exposure. And you will see that the cholecalciferol, which is vitamin D3, is now impacted on the liver, and that is actually through the dietary intake. Vitamin D2 as your supplements or your vitamin D3 for your fish and meat. And upon exposure to sunlight, it's converted already into 25 dehydroxy vitamin D3. Or, of course, this one now maintains the calcium balance in the body. So let's go further on the vitamin D in humans. So the melanin absorbs the UVB radiation. So you'll see that's the liver form 25-hydroxyvitamin, as I've said a while ago, converted into the kidney. And the 125D may further metabolize to inactive 124-25 vitamin D, or what we call the CYP24. So let's go further on this. If you'll notice, the 125D acts on the intestine where it stimulates calcium reabsorption, and upon bone where it promotes osteoblast differentiation and matrix calcification. The active hormones exert its effects on these tissues by binding to the vitamin D receptors, and that is what we call the VDR. Now this complex dimerizes with the retinoid X receptor, which is the RXR. And the 125D complex now with the 125D VDR and RXR, we call it heterodimer, translocates to the nucleus where it binds to the vitamin D responsive elements, which is the vitamin VDRE. Now in the promoter regions of vitamin D, this is now responsive genes, and it now induces further the expression of vitamins D responsive genes. Now many tissues on this particular accord other than the skeletal system, and it also expressed in the intestines. The VDR includes cells in the bone marrow, the brain, the colon, breast, and even the malignant cells. And the immune cell suggests that vitamin D may have functions other than the calcium and bone homeostasis. Additionally, tissues other than the kidneys express also the 1-alpha hydroxylase and are capable of converting the 25D to 125 D in non-renal compartments, and these are all the areas actually. Therefore, in addition to its endocrine functions, the vitamin D may act in a paracrine or autocrine manner. So some of the more recently recognized non-classical actions of vitamin D include effects upon cell proliferation and differentiation, as well as immunologic effects resulting in the ability to maintain the tolerance and to promote protective immunity. And that's the reason why your vitamin D is really meant to increase and boost the immune system, especially at this pandemic that we have. As an antigen-presenting cells like your macrophages and dendritic cells, the T cells and B cells actually have the necessary machinery to synthesize and respond to the 125D vitamin D that may act in a paracrine or autocrine manner in an immune environment. So going further in this actually, so this is actually moreover the circulation, wherein the local levels of the 125D may differ from systemic circulating levels, as local regulations of the enzymes synthesizing and inactivating vitamin D are different from the controls originating in the kidney. The extrarenal 1-alpha hydroxylase system is actually an enzyme wherein the macrophages differ from the renal hydroxylase, and it's not regulated by the PTH. Instead, it is dependent upon circulating levels on this area, or it may be induced by the cytokines such as your interferon alpha gamma and your interleukin 1 or your tumor necrosis factor alpha. So furthermore, the macrophages enzyme is a non-functional splice variant, so there is no negative feedback on the local 125D production. So if you'll notice here, so you have the intestines increasing the absorption of the calcium and your phosphorus. The bone increases the bone mineralization. Immune cells induces differentiation, and of course your tumor microenvironment, wherein of course it inhibits proliferation, induces differentiation, and inhibits angiogenesis as well. Alright, so your vitamin D actually from the diet is actually very multifactorial. So look at this. The vitamin D represents the D2 and the D3. So from this particular slide, actually, you can see that the PTH effects on the kidney, all right, and it's actually stimulating your kidney to increase the activation of vitamin D, promoting the phosphates excretion, and reduces, of course, the calcium resorption. Now, the PTH production, which is the main stimulus, which is low calcium, inhibited by the 125 hydroxy magnesium, is also required. Your calcitonin production, the area of your parathyroid hormone, is the main stimulus for the high calcium to be ionized. Also, glucagon, gastrin, beta-adrenergic agonists. Alright, and of course, last but not the least, your calcitonin that will be inhibiting the osteoclast resorption, thereby lowering the calcium and phosphate, no effect on the magnesium. Alright, so this is actually UVB radiation, wherein if you'll notice, you'll see here that the vitamin D is actually incorporated into the chylomicrons and which are absorbed into the lymphatic system and enter the venous blood. The vitamin D that comes from the skin or diet is biologically inert and requires its first hydroxylation in the liver by the vitamin D25 hydroxylase 225D. So however, your 25D OHD requires a further hydroxylation in the kidney, and by the 25D1 OH, which is CYP27B21, to form the biologically active form of your vitamin D1 125. So that is actually the active form. Your D125 OH2D. Now your 125 OH2D interacts with the vitamin D nuclear receptor, which is present in the small intestines, kidneys, and other tissues. So that is actually the stimulus per se. So actually this is just the unique among hormones because it can be made in the skin from exposure to sunlight. You see here that the vitamin D2 is obtained from the UV irradiation of the yeast steroergosterol, as I repeat it again. And then, of course, your vitamin D is coming from the present oil-rich fish, such as your salmon, your mackerel, and your herring. So, commercially available vitamin D3 is synthesized from the cholesterol, and the precursors are, of course, your dehydrocholesterol, as it enters already the body. So both vitamin D2 and vitamin D3 are used for food fortification and vitamin D supplements. So what about vitamin D and the protective immunity? So it's been used unknowingly before. It is actually also as an adjunct to treat infections such as tuberculosis before the advent of effective antibiotics. Now, the beneficial effects of vitamin D on protective immunity are due on its part to its effect on the immune system. As I said a while ago, the macrophages recognize your lipopolysaccharides, which is a surrogate bacterial infection through the toll-like receptors. Now, this engagement to the TLRs leads to a cascade of events that produces peptides with potent bactericidal activity, such as your catecholamine and your beta-defensin 4. So your catecholamides, which are peptides to co-localize with phagosomes with ingested bacteria, where they disrupt the bacterial cell membranes and have potent antimicrobacterial activity. Almost all of these slides were actually from the 19 materials that we got from the Hyphens Pharma, that they gave almost all of the medical evidence-based studies on this. So your vitamin D plays an important role as part of the innate antimicrobial response. So effect of the 125 vitamin D on T cells includes suppression of your T cell proliferation and a shift from the Th1 to the Th2 development. So as you inhibit this, there will be your monocytes in your dendritic cells, including the inhibitions of the inflammatory cytokine production by monocytes and inhibition of your dendritic cells differentiation and maturation. So very, very important, most specifically when we talk of the cytokine storm on our COVID patients. So your vitamin D and autoimmune illnesses, as for this matter, it's also increasing in epidemiologic evidence linking vitamin D deficiency and autoimmune diseases, including your multiple sclerosis, your rheumatoid arthritis, and diabetes mellitus, as well as your inflammatory bowel diseases and your systemic lupus erythematosus if you have a deficient amount of your vitamin D. Now, reports have shown also that if you have a low serum vitamin D, predicting the development of your autoimmune illnesses in the future have been published for all of these autoimmune illnesses. There's also data linking a decrease in neuter exposure to vitamin D and the islet cell autoimmunity. So lower in neuter exposure assessed by a lower maternal intake of vitamin D during pregnancy in women whose prospective child was at risk of developing autoimmune DM. So this is associated with a statistically increased risk of the child developing a pancreatic autoimmunity. So how important your vitamin D has also been shown to facilitate progression of existing autoimmune illness. In one study, 161 patients with an early undifferentiated connective tissue diseases were followed for a mean over 2 years, and most patients did not progress and remain in an undifferentiated state. About 35 or 21% of the study went on to develop a defined rheumatologic diagnosis, including RA, SLE, the mixed connective tissue disease, the Sjogren's disease, while 126 did not progress because they are the ones who were taking the vitamin D religiously. So with this, actually, the effect of your vitamin 125 vitamin D, the active form on T cells, includes suppression of the T cell proliferation and a shift from the Th1 to Th2 development, as said a while ago. So if we inhibit this, the effect of the monocytes and dendritic cells include inhibition of the inflammatory cytokines production, which is really, really good. Now, for immunologic function, once again, it will inhibit now your beta cells proliferation and blocks beta cell differentiation and immunoglobulin secretion. Now, we have a lot of patients coming to our clinic on a daily basis or on a weekly basis and presenting with this malar rash and this butterfly rash actually on the cheek area. And actually, these are your systematic or your SLE, your lupus erythematosus. There have been many studies on vitamin D status on lupus patients rather from across the globe. And actually, it typically lowers in patients that in disease or normal controls. Deficiency of the vitamin D is extremely common, often with more than 50% of the lupus patients with deficient levels and severe deficiency of the vitamin D. That is actually the levels less than 10 nanograms per ml. Now, disease's activity has been shown to correlate inversely with the vitamin D in many but not all studies. So similarly, between low levels of your vitamin D and disease activity and severity have been observed in other autoimmune illnesses such as your MS and your RA. Your vitamin D additionally suppresses your T cells proliferation and results in a shift from a Th1 to a Th2 phenotype. So furthermore, it affects also your T cell maturation, which is very nice. It's gears away from the inflammatory Th17 phenotype that facilitates the induction of T regulatory cells. So this affects results in decreased production of your inflammatory cytokines and would increase production in anti-inflammatory cytokines also. So to continue, your vitamin D also has effects on monocyte and dendritic cells. So additionally, it's given importance also for functional immune system and profound deficiency in autoimmune illnesses. As a correlation of deficiency with more active illnesses, an important issue is whether or not the immune components in the autoimmune illnesses are capable of responding appropriately to vitamin D. So that's the question now. If the patient is ill, can we still give the vitamin D? If this patient have a deficient amount of vitamin D prior to the illness, that is the question actually. So the immune cells, your beta cells, your T cells, your monocytes from the multiple autoimmune illnesses appear to respond to the immunomodulatory effects of the vitamin D. So example of your vitamin D responsiveness by your immunologic components in different autoimmune illnesses. This follows the beta cells or the B cells abnormalities from lupus patients and may be partially reversed by the vitamin D. So that is actually the good result of this particular study. So both spontaneous and stimulated immunoglobulin production from beta cells or B cells from active lupus patients are significantly decreased by the pre-incubating cells with your active 125 vitamin D. So additionally, pre-incubation with vitamin D significantly decreases also the spontaneous production of anti-DNA antibodies by approximately about 60%. While as for your T cells from patients with MS, they also respond to vitamin D. So your proliferation stimulated by your CD4 cells from your MS patients and controls are similarly inhibited after pre-incubation in increasing concentrations of your vitamin D. This is a very, very nice table actually. Now this table is actually your vitamin D recommended IOM by the Endocrinologic Practice Guidelines Committee in the United States, wherein if you'll see here from infants 0 to 6 months and 6 to 12 months, 400 IU is actually required for your 400 IU, but for your estimate, that's your estimated average requirement. But if you're having your recommended daily requirement, now you need about to give also 400 IU. Now, for the committee recommendations for patient at risk for vitamin D, still 400 to 1,000 IU for your infants. Now, the list goes on for children, pediatric age group 1 to 3 years old, 4 to 8 years old also. You have your 400 IU, 600 IU, 2,500 IU on a daily basis. But if he or she is deficient, now you can give as far as big as 4,000 IU. You go further on the age as the age increases on the males and the females because of the higher body mass on the males, alright, but if you'll notice, they have actually the same recommended daily allowance and actually for your estimated average requirements for all your males and females. Until 70 years old, if you can give actually 4,800 to 4,000 IU for both your males and female population, that would be a very, very good vitamin D supplementation. But if the patient is already deficient of the vitamin D and of course is ill of a particular ailment, so the recommendation is to go as broad as 10,000 IU on a daily basis. For pregnant patients, to again a while ago to do away with the autoimmune illness, diabetes mellitus for the fetus and utero, and it goes out of the womb. So until a pregnancy from 14 to 18 years old, so you have until 4,000 IU until 50 years old. So those are menopausally having their conception still. And of course, for if there's a deficient vitamin D, the recommendation is to go as far as 10,000 IU also. For those lactating mothers, until 10,000 IU for those who are deficient. So actually, this is a very, very good table to denounce, to see also. Again, for a study, this is evaluation and treatment and prevention of the vitamin D deficiency, which is an endocrine society clinical practice guideline. So these were actually their method. So the task force, what they did for it to become for it to be developed on an evidence-based clinical practice guidelines, they did a task force commission and they conducted in such a way for it to be able to do a two systematic reviews of the literature to inform its key recommendation. So the task force used consistent language and geographical descriptions of both the strength of recommendation and the quality of evidence using the recommendations of the grading of recommendations, assessment, development, and evaluation. Thus, there is what we call now the grade system. So with that, the clinical guidelines now, which is actually for the subcommittee of the Endocrine Society deemed vitamin D deficiency, which is a priority area in need of practice, guidelines and appointed a task force to formulate actually evidence-based recommendation. So without vitamin D, only 10 to 15% dietary calcium and about 60% of phosphorus are absorbed. So vitamin D sufficiency enhances calcium and phosphorus absorption by 30 to 40% and 80% respectively. So if you have the 125 OH2D that is interacting with the vitamin D receptor in the osteoblast to stimulate also the expression of your receptor activator of nuclear factor B ligand, this will in turn interact with your receptor activator nuclear factor B to induce immature monocytes to become mature osteoclast. So that's the reason why it's very good for bone absorption. Your vitamin D is very, very important as also as a vehicle along with the calcium to make the skeletal system more sturdy or more strong. Now, in kidneys, 125 2D stimulates calcium reabsorption from the glomerular filtrate. Your vitamin D receptor is present in most tissues and cells in the body. So this inhibits actually cellular proliferation, it induces terminal differentiation, inhibits angiogenesis, it stimulates insulin production, which is good for those who have DMs, inhibiting the renin production, and also for those who are hypertensive, and stimulating macrophage catalycidin production. So it stimulates its own destruction by enhancing the expression of your 25-hydroxyvitamin OH, and then it also metabolizes this 25 OHD2 and 125 OHD2D into water-soluble inactive forms. And actually, it was shown a while ago, there are several tissues and cells that possesses the 1-OH activity. So the local production may be responsible for regulating up to 200 genes that may facilitate many of the pleiotropic health benefits that have been reported for your vitamin D. So defining the severity, which is very important, there's an indicator wherein, of course, we need the circulating concentration of your 25 OHD. So if you have this as the parameter, you have your 25 OHD concentration, which is less than 20 nanogram per ml. We call that vitamin D deficiency. Okay, so but this is actually given by the Endocrine Society Clinical Practice Guidelines. And this is actually followed globally. If it's now 21 till 29 nanogram per ml, that is what we call vitamin D insufficiency only. But if it's of course 30 to 100, that is what we call the sufficient amount. So that is the spectrum: sufficiency, insufficiency, and of course deficiency. If you have less than 20, less than 10, that's severe deficiency actually. So diagnostic procedure. The Endocrine Society recommended screening for vitamin D deficiency in individuals at risk for deficiency. So they do not recommend population screening actually for vitamin D deficiency in individuals who are not at risk. So they recommended the serum circulating 25 hydroxy vitamin D. So that's the 25 OHD level, measured by a reliable assay to evaluate vitamin D status in patients who are at risk for vitamin D deficiency. So again, this is defined as below 20 ng, that is your deficiency, and your insufficiency is about 21 to 29. 30 and above is actually sufficiency. So this is recommend against using the serum 125 OHE assay for this purpose, and in favor of using it only in monitoring certain conditions such as acquired and inherited disorders of vitamin D and phosphate metabolism. So what they are recommending is a 25 OHD level. Now, this one is a very good slide because these are actually indications for your 25 OHD measurement. Who are the candidates for screening? Rickets, osteomalacia, osteoporosis, your chronic kidney ailment, hepatic failure, malabsorption syndromes, hyperparathyroidisms, those taking medications for anti-seizures, glucocorticoids, AIDS medications, antifungal, cholestyramine, of course your African American, Hispanic children and adults, pregnant lactating women, older adults with history of falls, with brittle bones already, history of non-traumatic fractures, obese children with more than 30 BMI, granuloma forming disorders such as your tuberculosis, sarcoidosis, histoplasmosis, coccidioidomycosis, and some lymphomas. Now, your vitamin deficiency is really prevalent worldwide, low in most diets, and changing in dietary patterns and varying exposure to sunlight. These are actually seen almost globally. It's a global pandemic wherein we had this pandemic back in March 2019, this SARS-CoV, and actually we didn't even have the time to test for the vitamin D levels of almost all of the members of each of the population in each country. But this particular data from the Hossen Arash study, they've shown also that it's really vitamin D is a global pandemic. If you notice, in general population in pregnant women, it was actually highest in European countries, Northern Europe, wherein the general population is really 92% deficient. Also in Canada, which is about 61% deficient. South America, 59% deficient. North Africa, 60% deficient. And of course, in South Africa, which is lowest, which is 7 to 20%. We also take note that in Asia, it's about 78 to 98% deficient for the population. So a lot of the members of in each of the country are really deficient of the vitamin D, and we really didn't even know that we're deficient of it. Now, the Russian Federation also has a 63% statistic. Now, for pregnant women, it's actually seen most in United States, which is about 91%. In Canada, about 65%. In Northern Europe, again, actually it's 100%. Anywhere, actually, almost all of the pregnant patients all over the world is really a global pandemic on deficiency of the vitamin D. Thus, it's really enforced right now because there's an increase high in Southeast Asia. 70% are vitamin D deficient in South Asia, and here in the Philippines, actually, from this study from Angeles and Villasalva, 48.7% are vitamin D deficient and insufficient amongst Filipino adults. So this is actually quite alarming. So is vitamin D supplementation beneficial in respiratory tract illnesses? Now, this is a study by Adrian Martu, wherein there's a supplementation of the vitamin D to prevent acute respiratory tract infections, which is a systematic review. What they did is that they got the 25 randomized controlled trials, which includes about 10,933 participants in various tests actually. So this is actually age 0 to 95 years old. 25 eligible randomized controlled trials, IPD, were obtained for 10 10,933, that's about 96.6% participants. Vitamin D supplementation reduced the risk of ARDS among all participants, and there was a good confidence rate of 95%. Now, in subgroup analysis, a protective effects were seen in those receiving daily or weekly vitamin D without additional bolus doses. So, just the right amount of the vitamin D without additional mega doses is actually seen on the wherein improvement were seen on these particular participants. Among those receiving daily or weekly vitamin D, the protective effects were stronger in those with baseline 25 hydroxy vitamin D levels. That's actually less than 25 and mole. And the vitamin D did not influence the proportion of participants experiencing at least one serious adverse event. So the body of evidence contributing to this analysis was assessed as being of high quality. So overall protective effect of the study of the vitamin D supplementation against acute respiratory tract illnesses was really stronger protective effect among those with baseline 25 OHD levels that were given. So the hydroxyvitamin D supports induction of the antimicrobial peptides in response to both viral and bacterial stimulus. So this suggests actually a potential mechanism by which vitamin D inducible protection against respiratory pathogens might be mediated. Now, your metabolites may have been reported to induce other innate antimicrobial effector mechanisms such as induction of your autophagy, synthesis of your reactive nitrogen intermediates, and reactive oxygen intermediates. So this is actually very good to increase the immune system further. This is a very good data wherein they would like to present the individual participant data meta-analysis. So, randomized controlled trials, the subgroup analysis revealed that the daily or weekly vitamin D supplementation without additional bolus, again, protected against ARDS. So, whereas regimens containing large boluses did not. So, this reduced the risk of experiencing at least one acute ARDS among those receiving daily, weekly vitamin D. Protective effects were strongest in those with profound vitamin D deficiency at baseline, and also those with higher baseline 25 hydroxy vitamin D concentration also experienced the benefit. So actually this was the evidence assessed as being high quality using the grade criteria by the endocrine association in the United States and European Federation. So since baseline vitamin D status and use of bolus doses varied considerably between studies, so still it suggests that the high degree of the heterogeneity between trials may be at least partly attributable to these factors. So the study conclusions is that it reports a major new indication for vitamin D supplementation. So the prevention of acute respiratory tract infection, which are for those people who are deficient of vitamin D and those receiving daily or weekly supplementation without additional bolus, it has a particular benefit. So the policy implication right now, these results add to the body of evidence supporting the introduction of public health measures such as food fortification to improve the vitamin D status of each of the individual globally, because we've seen a while ago that there is really a global pandemic also for vitamin D. So particularly in settings where profound vitamin deficiency is so common. So right now, I walk you through, are there any evidences of vitamin D in COVID-19? Now, COVID-19 has been lectured to us left and right by a lot of lecturers already. And we as doctors have been treating a lot of patients who are COVID-19 positive. So there's so many top of the news headline about vitamins D rolling out for vulnerable COVID-19 protection. There's so many reports already. And actually, this is actually a support report already. So this is vitamin D treatment and COVID-19 outcomes. So the objective of this study by Castillo Marta on the Journal of Steroid Biochemistry. Now, the objective is to see if the variety of actions on cells and tissues of vitamin D involved in COVID-19 progression, especially by decreasing the ARDS, because we know for a fact that the patients would succumb into cytokine storms, and this is the one that really presents the demise of the patients. So your calcifidiol, which is a form of vitamin D also, can rapidly increase serum 25 OHD concentration. This was evaluated and on the ICU patients already, and mortality rate among Spanish patients hospitalized for COVID-19. So the design was a parallel pilot, an open-label, double-masked clinical trial. They got all the informations also from that ICU, of course. 76 consecutive patients hospitalized with COVID-19 infection, clinical picture of ARDS, confirmed by radiographic pattern of viral pneumonia, and a positive SARS-CoV-2 PCR test with curve 65 severity scale, so recommending hospital admission already in a scale of totals of more than 1. All hospitalized patients by procedures received as best available therapy of the same standard care. As per hospital protocol, whatever is the symptom of the patient, this was given. Actually, hydrochloroquine, azithromycin, and all the list of the medications for COVID-19. Now, eligible patients were allocated at a 2 calcifediol as to 1 no calcifediol ratio through electronic randomization on the day of admission to take oral calcifediol. This is about 0.532 mg or not at all. So patients in the calcifediol treatment group continued with oral 0.26 mg on day 3 and 7, and then weekly until discharge or ICU admission. Outcomes of effectiveness included rate of ICU admission and deaths, actually, and these actually were the results. Of the 50 patients treated with the calcifediol, 1 required admission to the ICU, which is just 2%. But 26 untreated patients, 13 required admissions, 50%. And univariate risk for this particular ICU patients with calcifediol treatment versus the calcifediol treatment, which was really small, 0.02. For the multivariate risk estimated odd ratio for ICU in patients with calcifediol treatment versus without the treatment in ICU was 0.03, which is 95%. Of the patients treated with calcifediol, none died, and all were discharged without complications. And this was actually the very, very good news that was tackled on this particular study. And the 13 patients not treated with calcifediol who were not admitted to the ICU were discharged. Of the 13 patients admitted to the ICU, 2 died, and the remaining 11 were discharged. So, vitamin D treatment outcomes, this is actually very nice. So, as I was explaining a while ago, the calcifediol treatment group had significantly lower odds of ICU admissions. So, for those with the treatment group, none died, all discharged without complications. The control group, 13 non-ICU patients were discharged, 13 ICU patients, 2 died, 11 discharged. So the pilot study demonstrated that the administration of a high dose of calcifediol or 25-hydroxyvitamin, which is a main metabolite of vitamin D of the endocrine system, significantly reduced the need for ICU treatment for patients requiring hospitalizations due to proven COVID-19. Your calcifediol seems to be able to reduce the severity of the illness, but larger trials with groups properly matched will be required to show a definitive answer. So, however, even considering these factors, your calcifediol or vitamin D, 25-hydroxyvitamin, significantly decrease the need for ICU admission. And that is what is so important for our COVID-19 patients. It's a way that is not previously reported in this process until now. So, from a mechanistic perspective, there are good reasons to postulate that vitamin D endocrine system favorably modulates host responses to severe ARDS, coronavirus, SARS, both in the latter or the hyperinflammatory and early viremic phases of your COVID-19. So it's also important to highlight that the cuboidal cells and the alveolar coating cells type 2, like the cells of the immune system, express all the enzymatic endowment. And when you use your calcifediol as a substrate or a calcitriol with high basal expression of your 1-alpha hydroxylase activation and low expression of the enzymes, this will all actually result AC2, converting it to calcifediol to 125 to hormonal form endocrine system of your vitamin D. And all of this actually will be very, very good to increase regulation of your active vitamin D, and then synergizes the calcifediol and calcitriol sequentially to induce your cathelicidin. And what is so important, it will actually probably decrease the cytokine storm. So if you correct the vitamin D deficiency in severely sick patients, much higher doses of your vitamin D than usual are needed. So studies does not include comparison with your cholecalciferol. So that was the limitation of the study. Well, nonetheless, your calcifidel may have some advantages over just a simple native vitamin D. So your more reliable intestinal absorption can rapidly restore your serum concentrations of your 25-OHD. This is actually very relevant for those patients who have compromised expression already of your CYP2R1, and you wanted it demonstrated in several animals, of course, animal models, and has also been observed in patients with COPD or asthma. If you have an impaired CYP2R1. So in addition, calcifediol is more potent when compared to oral vitamin D3. So your high vitamin D is significantly reducing the need for ICU treatment of hospitalized COVID-19 patients. So it reduces the disease severity. So if you have low vitamin D levels, you have an increased COVID-19 severity and mortality. One of these study also by Marcos Pereira. Actually, they presented here that positive association between vitamin D deficiency and the severity of COVID-19. It increases the hospitalization by 95%. It increases severity by 95% as well, and increases the mortality by 95% if you are vitamin D deficient. So it's really high time to test the vitamin D level inside your patient's body. So the result of this study revealed that vitamin D deficiency can present association, especially in the elderly. So this is explained by both lower exposure to sunlight and lower 7-dehydrocholesterol values in the skin, which compromises the cutaneous synthesis of the vitamin D in the elderly. So moreover, aging is accompanied by a greater occurrence of chronic diseases. So you consider a risk factor for COVID-19 severity. So which are commonly treated with anti-inflammatory, antihypertensive drugs, or endocrine agents, and with drugs that can also interfere in blood vitamin D levels. So if you have the 25-OHD concentration, this is actually inversely associated with pro-inflammatory cytokines, increase in C-reactive protein, increase in risk of your DRA, cardiac insufficiency, and of course relate to the severity of the case and to unfavorable outcomes. So you really need a good level of your your vitamin D active. Despite higher levels of this being associated with defenses and with a favorable prognosis in other viral infection, it can be affirmed that there is rather association between 25 D deficiency and greater vulnerability to infection by your COVID-19, given that until now, no causal relationship has been tested and blood vitamin D levels have not been even evaluated in patients infected by SARS-CoV-2. So your vitamin D is not actually a usual laboratory test that we require or we test amongst or upon our patients if we see them in our clinics, right? So the study conclusions would say that the results of the meta-analysis confirming the high prevalence of the vitamin D deficiency in people with COVID-19, especially in the elderly, so the deficiency was not associated with COVID-19 infection, but it increases the risk actually. So observe a positive association between vitamin D deficiency and the severity of the illness. Evaluating blood vitamin D levels could be considered in the clinical practice of health professionals so that we can ready the bodily system of our patients for any type of ailment for that matter. Vitamin D supplementations could be considered in patients with vitamin D deficiency and insufficiency if they have COVID-19. So it can still be given. There is no support for supplementation amongst group with normal blood vitamin D values with the aim of prevention, prophylaxis, or reducing the severity of the disease. Not much really support for supplementation because of course it would say there's no approved therapeutic value in here. But then again, some of these studies are already pointing it out. So how do you treat vitamin D deficiency? Again, this is actually we have right now D Cure, which is which is able to quickly and safely increase the vitamin D status of patients with low vitamin D concentration. D Cure is actually a very soft 25,000 IU oral solution. So let's see. This was a treatment period given to some patients wherein 150 participants who are above 18 years old, all right, with vitamin D deficiency received 100,000 IU. Now, on group 2, they received 200,000 IU, and group 3 received 400,000 IU in 8 weeks, and the result showed like this. All right, so group 1, 50,000 IU, week 0, group and the third visit, which is week 4, 25,000 IU, visit 4, week 8, 25,000 IU, and that was the reason why it's 100,000. And group 2, 100,000. Visit 2, visit 3, 50,000. Visit 4, 50,000. That was the 200,000. And for the group 3, which is 200,000, 100,000, 100,000, which showed really an increase actually on the level, and this is actually the result. This is able to quickly and safely increase the vitamin D status of patients with a low vitamin D concentration. Higher increase with higher concentration of the group 4, which were in 400,000 IU for 8 weeks, is the best scheme to quickly and safely correct the vitamin D status deficiency. So D Cure was demonstrated to be safe as no variation in calcium levels and no clinically relevant adverse effects or events were observed among the groups after 3 months of treatment. So 98% of the vitamin D deficient patients achieved serum 25-OHD3 level, which is now more than 20 and nanogram per ml as early as week 8 with D Cure. So this time it's not even a vitamin D deficient anymore. So conclusion, demonstrated a dose-response relationship presenting a logarithmic pattern between 3 patient group. There's an increase of the dose administered and a plateau after 4 weeks. The higher dosing of your Vit D3, the greater the change in the 25 OHD3 serum concentration. Now, you're going to do a loading dose of your 200,000 IU followed by a monthly dose of your 100,000 IU. This is actually the dose tested in the study, and it's best one to quickly and safely correct the vitamin D deficiency status. So again, the same thing, week 8, observed higher doses. Will there be toxicity with the high dose of the vitamin D? That is now the next question that I'm sure all of you are wondering. So high dose vitamin D treatment is proven safe. So this is again a study by the Groningen Van group, where in this study no toxic effects were observed. Hypercalcemia did not even develop. Vitamin D levels were below the danger range, and complete suppression of the PTH levels was not observed. So the high dose vitamin D is proven safe. So this was published in the European Journal. The loading dose of your 25,000 IU every week for 8 weeks, and which is now a total of 200,000 IU for 8 weeks, showed no toxic effects, and which is really nice. It gave a good result of a before and after intake on almost all of these ions: your creatinine, total calcium level, phosphate, albumin, and your PTH. This laboratory test. So does high dosage of vitamin D causes toxicity? It only occurs when more than 150 nanogram ml serum level of 25D is given, or the dosage is more than 50,000 IU per day for several weeks or months. So that is the contention of the study. So multiple studies on D Cure observe highest value of serum level of your active vitamin D3, achieving ranges from 35 to 68 ng nanogram per ml, which is far from the concentration that might result in toxicity. So that's actually our D Cure 25,000 IU oral solution. So conclusions for your vitamin D with all of this: it has important functions beyond those of calcium and bone homeostasis, which include modulation of the innate and adaptive immune responses. It's prevalent in autoimmune illnesses as a deficiency, so we have to really address it. The cells of the immune system are capable of synthesizing and responding to your vitamin D. Your immune cells in autoimmune diseases are responsive to the ameliorative effects of your vitamin D, suggesting that the beneficial effects of supplementing vitamin D deficient individuals with your autoimmune illness may extend beyond effects of bone and calcium balance or homeostasis. So vitamin D does not increase the risk of COVID-19. And when you maintain an adequate nutrition, it's also essential for this particular global pandemic that we have, given that there are other important nutrients also, so we also need to give it to our patients, maintaining health and immune system modulation, such as, of course, your proteins, your polyunsaturated fatty acids, your B complexes, your vitamin C, your vitamin E, your folate, your minerals, your zinc, copper, selenium, amongst others. So here it is. The D Cure that I'm presenting, 25,000 IU oral solution, 1 ml solution in an ampule, clearly slightly yellow, oily liquid with an orange odor. So you cut it on this perforated line, and you take it as per RM. So you'll be wondering, because it's actually slimy, oily film. So I made a research, the solubilized cholecalciferol developed by the Dutch Pharmacists Association, wherein it's a watery mixture made of cholecalciferol concentrate, but in the case of D Cure, it's 25,000 IU. It's oil, citric acid, monohydrate, star anise oil. That's the reason why it gave that smell as well. And of course, potassium sorbates, your polysorbatum 80, sugar, syrup, and water. So it's a fat-soluble vitamin that is solubilized by your polysorbatum 80, an interface active substance that causes micelle formation. So after oral administration, the solubility changes into a very fine emulsion, so permitting it to go beyond with better bioavailability than oily formulations. That is what is so good about this one-of-a-kind D Cure 25,000 IU oral solution. So the therapeutic indications, the same thing as what I've discussed already, indicated for the prevention and treatment of vitamin D deficiency. It's an adjunct to specific therapy for your osteoporosis in patients with vitamin D deficiency or at risk for vitamin D insufficiency. The method of administration will be 1, preferably with meal, that's after meal. Administration to adults. Full contents of the ampule should be either emptied into the mouth and swallowed orally, or emptied onto a spoon taken orally. It can also be taken by mixing with a small amount of cold or lukewarm water if you're not used to taking pure oils only, or food immediately prior to use. Alright, so this is actually recommended doses of D Cure 25,000 IU for the treatment and prevention of vitamin D deficiency. So notice here, 50,000 IU per week, or 2 D Cure ampules per week. That's about 6 to 8 weeks for those who has been tested with a deficiency of vitamin D. So the maintenance now becomes 25,000 or 1 ampule per RM per month, which is really nice. For adults, alright, prevention is 25,000 IU monthly or 1 D Cure ampule per month. The duration is continuous. But let me tell you, because it's pandemic time right now and we need ample amount to really guard us and protect us, also help us to fight also the COVID infection that we see on a daily basis, as we're exposed to a lot of carriers that we don't know who are they, right? So I myself and a lot of my patients are taking 25,000 IU or 1 ampule weekly actually. So those with osteoporosis, 25,000 IU monthly or 1 D Cure ampule, and actually it has to be given, the duration is lifetime for those who have bone problems. So with that, urgently correcting the vitamin deficiency is essential for improvement of health, especially now during pandemic. Why is D Cure the preferred choice in vitamin D supplementations? First and foremost, first oral high-dose vitamin D3 approved by FDA Philippines. So clinically effective to increase the active levels from deficiency to sufficiency in just 3 months period. Safe and well tolerated. It's so easy to open. You just put it per RM, reduces the burden of a daily pill intake, and better patients' compliance with monthly dosing, easy and safe use. You don't even need to take vitamin D every day, all right? Because you already have one pack of that in a weekly basis or a monthly basis. So nothing to lose, but potentially much to gain. So that is actually vitamin D3 from D Cure. With that, thank you very much, ladies and gentlemen.